Hello, and welcome to our webinar on Justice Involved 101. My name is Linda Fallwetter. I'm a nurse practitioner. I've spent much of my career working to improve the quality and access to healthcare in jails and prisons nationally, as well as connecting people into care once they're released and diversion prior to incarceration. I'm going to be talking about some of the changes that have been involved with the Justice Involved initiative that's been started in California by DHS as part of the 1115 waiver, and also provide some context and background in helping to understand um, carceral settings and how people receive healthcare in carceral settings. One of the major goals for the CalAIM Justice Involved initiative is to make sure that people who are in carceral settings receive the support and the connections that they need as they transition back into the community to connect into important services that can help to improve their health outcomes and are hopefully associated with decreasing people being reincarcerated. Some of those services are care management and including enhanced care management in the community, as well as community supports and behavioral health connections. Managed care plans are going to play a critical role in coordinating this transition from pre-release to post-release or transition into the community, sometimes called reentry as well. Um, and that in particular will be with a 90-day pre-release period when people will be eligible for services, um, and during which time they would be assigned to a managed care plan and begin to receive services through a managed care plan. When we look at rates of incarceration nationally, we have the diagram on the right of the screen, which shows that about half of the people that are in carceral settings are in prisons, and another proportion are in jails and federal prisons. And if we look at California, which is on the left of the screen, you can see that roughly aligns with the national distribution for people in state prisons and local jails. Overall, the United States incarcerates at a much higher rate than other nations. So our overall rate per 100,000 is 664 in the United States, and which is, as you can see from the graph, much higher than other countries. And you can also see that California actually has an incarceration rate much higher than most other countries. So, one of the big contributors to our rate of incarceration actually has been change is in the way that people are sentenced and the law and policy around that, not necessarily a change in the rate of crime, but in fact, the United States policy on drugs, just say no, as well as going hard on crime, increase the rate of incarceration. We are beginning to see trends heading in a different direction as some places are starting to do um, no bond, so people are released rather than into the community for lesser charges rather than being incarcerated. So again, California on the right, you can see this graph begins at 1980 in California, which is at the line, and you can see California mimic most of the country as far as incarceration rates with those changes in laws. We also want to start as well with discussing how important and stigmatizing language can be. So DHCS has taken a step in using person first language, which would be rather than saying an inmate or a felon, you would say a person with justice involvement, or it could a person recently released from a carceral facility, recently released from jail. Um, Also, words like inmate, offender, and prisoner are seldom used outside of a carceral setting, and those actually that language can be stigmatizing. So We really are trying to move away from that type of language. Another important consideration thing to be aware of is that we incarcerate persons of color at a much higher rate than other uh, um, in the United States. Um, in the graphs that you can see, the incarceration for um, whites, which is in the first bar, uh, while the whites make up 36% of the residents in California, they're 20% of prisons and jails. And while Blacks, non Hispanic, make up 5% of the overall population, within prisons, they're 28% of persons incarcerated, and jails, 21%. You can see similar trends with the other persons of color represented here. Also, additionally, uh, indigenous people have are incarcerated at almost a four-time rate over what their population is within the general community. So this is another it's an overrepresentation for persons of color. One of the things that people frequently ask about is what is the difference between a jail and a prison? How are they different? When a person is taken into custody, they will either go in California, either a jail or a prison. There are also federal correctional facilities that are separate. But the primarily we'll be talking about jails and prisons that are in California. In a jail, a person is taken um, when they're taken into custody, they can be there before adjudication, which is before they're sentenced, while they're waiting to be sentenced or waiting to go on trial. Sometimes this is there. Could be because they can't meet a bail requirement. Some people are held without bail based on the severity of their charges. But one of the big differences between jails and prisons is that typically for prisons, people are housed in a prison after they've been convicted of a criminal offense and they have a sentence. We do hold people that have been sentenced in jails, and but typically if they're sentenced to a year or less. Um, uh, so that's roughly how you can tell the difference between jails and prisons. And this is important to know when we talk about how people are going to be released into the community. So, roughly 787,000 men and 201,000 women are released in California from jails and prisons each year. Another thing that's important to think about with jails and prisons is how is healthcare delivered in jails and prisons? Because in a prison, people are sentenced for longer, they actually can end up having a more stable plan of care and they have access to healthcare and healthcare services the entire time they're incarcerated in a prison. It's typically provided by state employees in California. The healthcare provision is through the state, and we know when people are going to be released because they're released on the date of their when their sentence ends. We can't hold people in custody longer than they're sentenced. Um, this is important because unlike being released from a hospital setting or other clinical setting, you are released related to charges, which are totally agnostic of your clinical health at that point. In prisons, because people are in there longer, frequently their conditions have stabilized and they've been in treatment for a while prior to um, being released. There are higher rates of physical and behavioral health conditions for people in prisons, and that includes opioid use disorder and substance use disorder. In um, jails, actually, people stay for a much shorter period of time. Approximately 60% of people are taken in and released in less than 4 weeks. And actually, many people are released in the first 72 hours of the time that they're taken into custody. So, thousands of people move through jails annually, and healthcare in California is typically provided by vendors. In some areas, it's by county employees as well. Again, there's high rates of physical and behavioral health conditions, including opioid use disorder, substance use disorder, and other chronic diseases like hypertension and diabetes. Um, and then, and it's a great public health opportunity to identify people that need um, follow up in the community for treatment and healthcare. And as I said, as you can see, this being released um, based on charges or your ability to make bail is totally unrelated to what type of clinical need that you may have. So, jails in particular present a very unique challenge as we look at 1115 waivers and providing um, reentry and transition into the community care. So, in addition to people being in jails and prisons, there's millions more people who are under probation, parole, pretrial supervision, specialty court supervision, as well as other alternatives to custody. We consider, um, I consider jails and prisons just another point in the continuum of care for many Americans. For some Americans, jail or prison can be the first time that they receive consistent, regular care. And many times people have had underlying conditions and they aren't diagnosed until they're into a jail or a prison. Jails and prisons are unlike any most other types of healthcare settings. They're a congregate setting, so that means people live together in close proximity. Jails and prisons provide care at many different levels of service. It can actually provide inpatient level care, depending on the facility, as well as ambulatory episodic care and everything in between. The care that is provided is comprehensive, so diagnostics, imaging, medications, dialysis, all of these can occur for people while they're in jail and prison, and if there's care that can't be performed within the facility, they're referred to outside provider. It's important to provide care in a timely way because it's the only access to care for a person who's incarcerated. When we look at how many people are seen in jails and prisons for healthcare, some of the studies that have been performed show that about half of the people in our prisons report a chronic medical condition, and 65% report um, drug use, illicit drug use prior to arrest. 43% report a history of mental health problems. So this is an opportunity to really identify people at risk for improved outcomes through enhanced care management and poor outcomes for not being connected appropriately to care. Black, Indigenous, and Latinx persons, in particular, experience incarceration as a major social determinant of health. Um, so, transitions into the community can increase risks for poor outcomes for people. So, one example of this is substance use disorder. It's estimated that 63% of jail and 58% of people in prison have a history of substance use disorder. This is probably an underestimate. It's very conservative. Um, and historically, many jails and prisons have not provided medication assisted treatment or medications for opioid use disorder for people's incarceral settings. More typically, people were medically assisted through a withdrawal process from substances that they were addicted to. Among individuals who are released from prison, when they're released from prisons, studies and jails as well, opioid overdose can be a leading cause of death. From prisons, it's a tenfold over the general population for risk of death. And it's driven by in the first 2 weeks after release. So connecting people early into care can make a huge difference to improving outcomes for people with substance use disorder. And it's been estimated that that can decrease that overdose rate by 60 to 80% with timely access to medication. Additionally, providing MAT and MOUD to persons in carceral settings also has a huge impact on them connecting into care even independently when they're released. And the 1115 waiver is strongly supports that MAT and MOUD in facilities. Almost everyone who goes into jail or prison will eventually be released and return to their communities. And um, it's im- it's important for our communities and the health of our communities that we acknowledge that and we try to help keep people as healthy as we can. For the purposes of the, the 1115 waiver, they define a person with justice involvement or the justice involved population as someone who is currently or formerly incarcerated within the past 12 months. And that's the JI population. But you may hear people refer to it as any point in your life having a connection to a carceral setting. But for the purposes of the waiver, it's people who have been incarcerated within the last 12 months. I wanted to take you just on a little bit of a journey of how people typically enter. And in this first example is a jail. People will be arrested in the community. They may be housed in the community or taken directly to a carceral setting to await bond, court, or arraignment. So within the first 24 hours, they'll have a decision made about whether they'll be taken into custody or remanded into custody or released on their own recognizance or released on bond. If they're remanded into custody, custody does a screening, and a licensed clinician typically also does a screening to make sure that they're healthy enough to enter the jail, and also to see if they have any active medical conditions, mental health issues, or substance use disorder. And this initial screening is used to help with housing assignments, and alerts based on their needs. As I said, there's multiple levels of care provided, and this information helps people to make a decision about where people should be housed. This is frequently called the intake process. The area in a jail or prison where this is done is called intake as well. And as said before, it's important even to reinforce that your um, your time in custody is related to your criminal charges and not based on your clinical need. So it could happen that people are released into an emergency room because they're actively sick, but we don't hold people in custody to treat a clinical condition. They're released based on their charges. Healthcare needs for people are variable. A lot of people are very healthy when they come in, but others also have a lot of underlying chronic conditions. And their level of risk is typically dependent on how well controlled their conditions are and if they have available care in the community. So sometimes people who are poorly controlled um, can create higher risk for a poor outcome. I think also when you think of jails, it's good to keep in mind that about 60% of people in the California jails that are in custody have not been convicted of a crime. So, as I said um, earlier, you're waiting for its jails are pre-adjudication or pre-charges and sentencing. So, uh, it's important to, I think, to think of that. We've put together actually a table of the counties where HealthNet and their partners, CalViva and Community Health Plan, provide services. And to give you just a sense of potential volume for that, we have each of the counties in the first column. In the second column, we're what portion of the county market is what the county market share is for HealthNet. You can see that varies by community. And the next area um, the jails, we're looking specifically at jails here. Um, if it's a single jail, we've listed the name of the jail, and then in some counties, there's several jails. So if you look at the bottom on the left, you can see Los Angeles, it's 7 jails, and there's the average daily population, or ADP, is average daily population within that jail. Uh, for example, in LA is 16,703. So if all of those persons were Medicaid eligible, 15% of that population would fall into a potential health net um, member. So there's additional factors, in California, health conditions that have to be available. But just to kind of give a sense, if you're working with a specific community, specific county, hopefully this can be a nice tool just to give you a sense of the numbers you're looking at. So if you look at Mono, has an average daily population of 26 in the whole jail, of which we have at that county have a 36% market share. As these programs move further along, our numbers will get uh, better and better on this as we begin to see people move through and see how many people are actually members, and members also that have are have access to enhanced care management services and other services. Prisons are different. So in a prison, uh, this is once you've been sentenced. So people leave jails once they're sentenced and they're transported to prisons. They receive another intake screening during prison. They also go over with their healthcare records for the cares and services that were provided within the jail, and they're assigned housing while they're in the prison facility. People, when they transition through prisons, come with their medical records. Frequently, they have their meds that are transported with them as well, and they receive another screening and assessment within the first 14 days. They'll receive orders for ongoing clinical care, medical care. They'll also see psychiatric care. Dental care is provided in both jails and prisons as well. This is another table that tells you for each of the counties where there's a prison located, and that actually also the name of the prisons as well. I think, but what's important to realize is that the difference between, again, jails and prisons. In jails, it's frequently people from that county go into their county jail. Prisons are um, prisons operate as a larger single entity, and they house people based on their level of charges and other factors. So, for instance, women would be housed all together in one prison. When the women are released, they don't go to the county around the specific prison. They return back to the community where they came from. On the right, we have a visual that kind of shows, if you look at, uh, again, for prisons, and if you look at just Los Angeles, what you can see in the dark blue in the corner is for a large county like Los Angeles, people that are released from any of the prisons in California, the majority of people that are returned actually return to a small geographical area within within Los Angeles. So I think what it does is helps us as we plan to have a sense of that as well. So if we looked again at all the counties that are served by HealthNet, what um, what this shows is what number of people identify that county in the prison system, identify that county as where they've come from. And interestingly enough, two of the counties that where we have the health net members, Kings and Tulare, have some of the highest rates for imprisonment in the state of California. And so on the map on the right, you can see the counties with the representation of the rate for incarceration. and this gives you a sense as far as typically people would return to that community, the community where they lived prior when they're released. Additionally, it's important to know how healthcare services are delivered in jails and prisons. In 1976, there was a federal court decision which deemed it to be cruel and unusual punishment if people were denied access to healthcare, food, exercise, or hygiene while they were incarcerated. So there is the provision of healthcare. In many places, there's healthcare contracts. Many jails use vendors that the sheriff hires to provide healthcare that they're contracted with. And they have arrangements that it may be a single provider for all services. Some jails have multiple providers for services. So they may have a separate behavioral health provider, dental provider, and physical health provider, a dialysis provider. Um, and the payment models are different um, as well for most jails. The California Department of Corrections and Rehabilitation uses county employed clinicians and allied support for clinical services. So they are state, um, it's a health group from the state for specifically for prison health care. Additionally, jails budgets can what they spend on health county to county can vary significantly, and what type of services they provide can be different. So it's important to get to know the county or the jail, local jail that you're working with, or your ECM provider is working with in that area. There may or may there may be not have 24-hour coverage for medical and nursing staff, and maybe an on-call staff, depending on how large the jail is. And uh, it also may delay screenings if someone clinically isn't present there as well. Additionally, smaller jails, ones that are under 500 ADP or average daily population, are less likely to provide continuous clinical services throughout the day due to resource constraints compared to larger facilities. And many of them just utilize local emergency rooms send people out for healthcare and evaluation. So there's a lot of variability in the way that healthcare is provided in carceral settings in California, as well as across the nation. I wanted to drive home the point as far as the different levels of care, the levels of service that are provided in jails and prisons and carceral settings. Uh, a medical inpatient level of care is typically done in an outside hospital, but an inpatient level of psychiatric care, it is not uncommon for this to be done, provided within the carceral setting, depending, as we said on the earlier slide, on the size of the facility. But certainly within the prison system and in many jails, um, LA County included, an inpatient level of psychiatric care is provided, and there's a large staff of psychiatrists and other mental health specialists there. There's also acute and urgent care. Emergent care is provided in jail and prisons. Some places actually have an urgent care where people can be seen, or have walk in where people can come in. Smaller places, as we discussed earlier, send people out for that as well. Um, and behavioral health will deal with suicidality and self harm in an acute and urgent way on site as well. Additionally, there's a large group of people that are ambulatory. We'll have episodic care, screenings, health screenings, um, ongoing regular care is provided for people as well, and that can include all different type of diagnostics and specialty services. As and this as well for behavioral health, ongoing counseling and programs are provided. There's frequently a special care unit which would provide like custodial or activities of daily living type care for and uh, specialty care is also provided. Um, Frequently, ortho, cardiac, um, and other types of specialty care patients are taken off site for that as well. One of the areas for specialty services in jails and prisons is medication assisted treatment for substance use disorder, as well as some jails and prisons do gender affirming care, other types of care um, as well. And for dental, there's emergent screening and maintenance care is also provided. So I think a lot of people don't realize how much healthcare is provided in a jail and prison setting. Um, that being said, not all jails or prisons have electronic health records. There are actually some jails and prisons that are still on paper. Some have electronic health records that are very specific to carceral settings, and some actually have community electronic health records that they've adapted for carceral settings. But data can be a real challenge in jails and prison settings. The addition to the electronic health record, jails and prisons themselves have custody management systems, which may or may not interface with EHR, and those provide information on court dates. They also are the first to have information on release, um, and they also provide information on housing and any alerts that are tied to a person as well. Custody or security and healthcare can share information on a need to know basis, but the health system is covered entity for HIPAA, and they have to abide by all HIPAA requirements. And the um, custody staff is not a covered entity for HIPAA, so they don't. So it's need to know typically basis for between custody and healthcare. And custody is required to provide privacy to allow people to they can see but not listen to a healthcare interaction um, and the privacy for the person. It's an expectation that personal health information and privacy be maintained with records and visits. Some of the information that might be shared, for example, is if a patient has a CPAP machine that requires an outlet. Typically in jails and prisons, there's not outlets in all the living areas. So it would need to be communicated to custody that this person needs to be housed near an electrical outlet. Or if someone's at risk for withdrawal, frequently they're housed or cohorted in the same area to allow for closer observation by nursing staff. So there might be an alert for that as well. People who have a history of seizures or at risk for seizures, there might be an alert to make sure the person is housed and assigned a low bunk, so they're not in a high bunk. So those are just some examples of things that may be communicated without necessarily the diagnosis being communicated to the custody side. With our 1115 waiver and the reentry initiatives that have come forward, it's real focus on improving access for the people that we talked about with the burden of physical and behavioral health um, needs, how to connect them into the community. And some of the challenges with this is we're talking, as we talk, custody who have never done billing or encounter. And this is all novel for them. For some of the healthcare providers, even in the space, they've never um, have never done that. Perhaps in their career, they've worked their entire career in carceral health. So the data exchange and the data interconnectivity is going to be is a critical piece that's being built out early on. It was part of phase two for the 1115 waiver. Additionally, billing and claims is a piece that's being developed. The managed care organization, their engagement, um, their role, and notification and how information is communicated is important. Assessments and the development of care plans and care coordination, as well as the pharmacy, um, things like long-acting injectable. Also, on release, people are going to be released with a 30-day supply of their medication, and there's an enhanced role for peers and community health workers in the 1115 waiver. Um, if we look at the statistics around people who leave prison and jail, um, there's much a higher burden for serious psychological distress, history of mental health problems, and mental health problems, and also for substance use disorder compared to the general population, and also more chronic conditions. So you can see more infectious disease and uh, for example, some of the chronic diseases like high blood pressure, tuberculosis, hepatitis, and HIV is higher than that typically found in the general population. I'd like to say that the slides that we've gotten here is from the Bureau of Justice Statistics, but you notice that they're not using first person language as we will be. So um, hopefully you recognize that, but we in keeping true to the slide here in the source of information, but there's definitely a higher burden for people in persons in carceral settings for these diseases to be aware. This is kind of just a flow of how people move in with the 1115 waiver, how it will look. On the far left in um, the orange, at the top, you have an individual who will enter the carceral setting. At that point, the expectation is very early on. There's going to be a screening to see if the person is eligible for Medicaid. If they're uh, not currently enrolled in Medicaid, but they are eligible, they'll be assisted in their enrollment. Um, at simultaneously or very close to that same time, a medical exam will be performed, which will include hopefully a release of information as well as a screening, addiction screening, and a screening for other type of clinical diagnoses, past medical history, medications. If there's any outstanding orders for continuity medications, like medication assisted treatment, those would be carried forward for that person as well. If they meet the criteria for um, those chronic illnesses or substance use disorder, they would then be um, assigned a JI. That that would be triggered that they're eligible for the justice involved services as part of the 1115 waiver. In jails, as we talked about earlier, not knowing when people are going to be released, there is some challenge with the 90-day pre-release. Some people will be released before, prior to the 90 days of incarceration. But it's another reason why it's critical to get people enrolled and identified early. Their pre-release services then will start. Those would be fee for service while they're in custody, and then they would also identify health-related service needs for people if they're available. And this care management alert would be generated in the electronic medical record and the carceral management system. They would continue to receive medical care while they're in the facility, including planning for release. And then they would also receive the care management services while they're in the facility to help to coordinate and plan appointments and transitioning behavioral health and MAT services. The embedded or in-reach care manager will work closely with the enhanced care manager, the ECM, in the community to have a cooperative discharge for this person across all the service lines that they need help to seamlessly connect them into community care and also to supply them with 30 days of med. And then uh, and then they're released back into the community where they would receive care and follow the plan of care that was established for them while they're in the carceral facility. So this is the ultimate goal to look like this. Another thing um, that we're aware of as people are released into the community, um, without the services that we talked about in the previous slides, without identifying and connecting people into resources, if we release people without access to care, without access to continuity, without prescriptions for the meds that have helped to stabilize them during the time that they were incarcerated, that they'll seek care in an emergency room or a hospital setting. Um, Sometimes they'll decompensate in the community trying to find care, or because they don't have access to care and end up in an emergency room. But in studies that have been done, it when they speak to people who are released, many of them use the emergency room as the regular source of care. Additionally, um, the population of people who were formerly incarcerated, or at least carceral settings, 1 in 70 persons were hospitalized within 7 days of the release, and 1 in 12 were hospitalized within 90 days of release. Much of this potentially could be avoided if the person was connected into care in the community and had ongoing continuity care. Additionally, um, we we also know that there can be disruptions in insurance coverage, and also some persons that have in carceral settings perhaps never enrolled in insurance. So having a stable um, payer for healthcare services is anticipated to be to help to prevent inappropriate level of service, um, care for many of these patients, and can prevent perhaps many acute and non-urgent um, emergency utilization patterns. So the overall goal with the opportunities that the 1115 waiver creates is, as we said, um, our health net members, including health net members who are persons who've uh, moved through carceral settings, have we have an opportunity to really improve their overall outcomes. Um, the additional data that we'll be able to gather now on people will help us to focus and create better plans of care, and to identify risk. We'll also be able to um, help formalize the screenings and the tools that are used in the carceral settings and with the care managers to make sure that we're appropriately identifying people at the highest risk, and getting them timely access to care. We'll be able to connect people in the community to primary care and behavioral health services and identify those at highest risk for poor outcomes um, due to loss of follow up or need for additional care management or supportive services. And additionally, the inReach will help to establish a relationship and strengthen patient engagement, or create that stickiness where a person wants to follow up in the community with their provider. These Creating these smooth transitions should help to mitigate patient and system risk for poor outcomes or inappropriate level of service care, which again can also lead to poor outcomes. So um, this is the goal of the 1115 waiver. This is population justice involved, and I want to thank you for your attention and time today. And I also want to thank you for the care that you're providing to this very important and vulnerable section of our communities. Um, Thank you.